Perfect. How did you feel, Dr. Shashak?
I think I was way beyond the time thing. I think I was struggling with the time.
Do you know why?
I think I was a bit more slow with long sentences in terms of data gathering.
Okay. But do you know why as well?
Um,
Do you know why you were slow? Anybody knows why? Anybody knows why? No answer. I'll tell you why.
yeah.
The problem was you didn't start with an open question.
Okay.
So, open question gives you more information than closed questions.
Yeah.
Okay. Yes, many people tend to think about an open question, meaning, how can I help you today? No, this is not the open question. The open question is, please tell me more about what's been going on. And the patient will tell you more. The patient will tell you more information than what you think. You might actually, because we kept going round and round in circles when I was saying, oh, I've been having shortness of breath. Twice. I said that twice, and we didn't reflect on that, did we? Because that was supposed to be happening early on. You don't have to ask this question directly. The patient will tell you. But if you only give me a chance to tell you, if you know what I mean. How to give me a chance to tell you? I have the ECG with me today. All right? Well, can you please tell me more about what's been going on so that I can help you in a better way? So that I can put everything into context. The patient will tell you everything. Okay? Everything you need to know. Everything you need to know to pass this consultation. Everything you need to know to reduce your data gathering. But if you start, oh, have you got any chest pain? Have you got any palpitations? Tell me more about palpitations. Tell me more about this, about this. If you say, tell me more about this, the patient will only tell you information about this, but she will not tell you information about what's been going on. Okay? Did you know that this patient has heart failure as well?
Yeah.
It's mentioned in the notes, isn't it? And she has what? She has breathlessness.
Yeah.
Okay. What does it mean?
So
It might be nothing. It might be because of, did you know? So let me ask this question. Atrial fibrillation, does it cause shortness of breath?
shortness of breath now.
Okay. Anybody else knows? Atrial fibrillation can cause shortness of breath. Okay? Atrial fibrillation can cause that, but she also has heart failure, which can cause shortness of breath. She mentioned to you that she has been also having some ankle swelling, right?
She did.
Yeah, yeah. And what does that mean?
She needs to come in today to have a review.
It's okay. It's okay. It's not urgent anyways. It doesn't have to be today, right? First of all, to start with. But what does that tell you?
It's probably a flare-up of heart failure.
Amazing. Amazing. She has ankle swelling, and also she has heart failure, and she is not on what?
The diuretics.
Furosemide. Yes. Amazing. So you see, this is how you can think like a GP. Think holistically. Think holistically. So when you start your consultation, what would you like to talk about today if you don't have any information in the notes? However, if I do have information, I can see from my notes that you booked this consultation today to discuss the ECG, the heart tracing. Am I correct, or are we discussing anything else? This will build rapport, not only with the patient, but with the examiner. Why? The examiner will know that you have read notes carefully.
Yeah.
This will also build rapport with the patient. Why? Imagine I can really bet every one of you, you see a patient or two at least every day. I'll tell you, oh, doctor, I'm not quite sure if you managed to have a look through my notes. Doctor, I'm not quite sure if you had a look through my notes. Okay? Why is that? Because patients actually, unfortunately, they are fed up. Every single time they go and see different GP, they go and see different healthcare professional. They have to start from the beginning every single time. But if they know that you already read the notes, if they know that you already, know information about this patient before they come to you, so they will be pleased. Okay, that will build rapport with them. This is what we are after. Okay, so take home message. First one is, when you start, please try to take some information from notes if there are any. If there aren't, that's fine. Instead of how can I help you today, I prefer what would you like to discuss today instead. Okay, so this is very important. Then this is not your open question. The open question, can you please tell me more about what's been going on? Okay, and when the patient tells you more, that will save your time. So you don't have to ask too many questions. You only ask questions that are related to this consultation, if you know what I mean. Now, we are going round and round in circles. You know what? You also asked me 4 questions on one go. Then I had to be very blunt. I had to say yes and no. Yes and no. And this happens. This happens. If you rush to ask too many questions, then what happened? Then I said yes and no. Then what happened? That again slowed you down. Because you were thinking that if I asked 3 questions, 4 questions all at once, and then that's going to save my time. But imagine what happened. Actually slowed you down. So ask every question on a roll. Don't ask too many questions all at once. Okay, okay, right, perfect. So, present a complaint, differential diagnosis, red flag were fine, but again, they were limited to your questions, not to what the patient wanted you to explore. You ask about home, ask about work, smoking alcohol, which is also fine, but any recreational drugs, I would signpost before asking this question. So this is very important. She's 62 years old, but even though if she's 20 years old, a patient is 19 years old, I wouldn't jump and say, do you do any recreational drugs? Routine question I normally ask my patients about, if that's okay. And do you do any recreational drugs by any chance? Okay, always signpost before asking this question. Family history, you asked me about that, and medication, which is very, very good. Now, going to our interpersonal skills. So you took eyes from the patient, but you addressed most of eyes apart from one thing, which was what?
The breathing symptoms.
What was her concern for today?
About the stroke.
Did we address that she doesn't have stroke?
I didn't. Yeah, there were no symptoms about the strokes. Yeah, I should have. I asked her about the symptoms, but I didn't address them.
So, take home message, another one. Interpersonal skills is not about gaining eyes from the patient. It's all about as well reflecting on the patient's eyes. The best way of doing it, not to forget, write it very clearly on your whiteboard whenever you are practicing, whenever you're doing mocks. Eyes. If you manage to take eyes, put it down. Just one word in front of I. One, for example, I, 0. So she doesn't have any idea here. Concern, C, stroke. Expectation, E, results. Okay, so this is how, write it down. Once you manage to address the patients, then put a tick in front of it. So, idea, did I address the patient idea? Tick. On your whiteboard, in your exam. Stroke, did I manage to address it? Yes, then tick. If I don't tick it, this means that it's still, needs to be addressed. Okay, so this is very important. Perfect. Diagnosis. Yes, I mean, diagnosis, you explained what AF is, which is very good. But what else slowed you down here? Do you know what? What slowed you down? I asked you too many questions. Do you know why? Do you know why? And when we were explaining about the diagnosis, doctor, is it serious? Doctor, why am I having this? Doctor, you know why I'm asking these questions? Because you didn't tell me. All right? Anybody knows what the structure for a diagnosis is? Did you know that there is a structure for diagnosis? Did you know that? No. Anybody knows what the structure is? Because this is something that I invented myself. Structure. Always think about it. Is it a long-term condition? Is it a short-term condition? First of all, AF, is it a long-term condition or is it a short-term medical condition?
Long-term.
Perfect. Is it a common, uncommon, or is it a fairly common medical condition? What do you think?
It can be common.
It is a common medical condition, yeah, and then explain what AF is.
Okay.
This is time for explanation. Then, after that, this condition, is it a treatable condition, untreatable condition, or is it a self-resolving condition, or it can be brought under control? What do you think?
It can be brought under control.
Perfect. Last but not least, what happens if this condition is left untreated? What do you think?
The complications like the
Yeah.
stroke.
If you manage to say all of that into the structure of diagnosis, the patient will not waste your time asking you to me, and doctor, is it serious? Doctor, why am I having this? Doctor, is there any medication to treat it? Doctor. So if you know what I mean. So if you manage to say that, and then stop and say, how do you feel about that?
Mm.
Are we on the same page? Any questions so far? Okay. This is how to explain any diagnosis on earth, really any diagnosis on earth. So very important to have this structure. Now, when we started to talk about the medication, DOAC is not a medication, you know, then I had to stop you. What's the name of the medication again, doctor? Okay. So yes, Mrcgp, for example. Whenever, as a general rule, whenever you are prescribing a medication to a patient, so always try to tell the patient the pros and cons. Focus more on the pros and give less information about the cons. So, for example, it's a very good medication that really and prevents things from happening in the first place, like stroke, like TIA. Okay, so it's a very good medication. However, it can thin your blood to some extent, can cause some bleeding, but it doesn't happen so often. But please, if that does happen, get back in touch with us straight away. Okay, perfect. Any medication like that, bisoprolol, the same thing. All right, fine. What else? What is the specials that you're gonna seek advice from Dr. Shirshek? You told me cardiologist. Any other thoughts?
Hematology.
Okay. Any other thoughts? Anyone else?
Mm.
Who prescribed clopidogrel in the first place, do you think?
The cardiologist or the GP.
Right. Okay. As well as because also the patient has been having a stroke, a previous stroke. So it's good also to double check that with the stroke team as well. If the patient can stop clopidogrel and can be on Mrcgp, but that's not the only thing. What else? Remember this patient. Now, this point, we are talking about the clear pass point. This is the one that I'm going to talk about now. Okay, please focus on it. Now, have we solved the AF problem or have we not? Have we treated it? Are we giving the patient treatment for it? We are. Okay, but now this is the time of the clear pass, which is thinking holistically. What else this patient is having?
The shortness of breath.
Yes. Heart failure, right? What can we do for this patient when it comes to her heart failure as well?
We can use some loop diuretics on a dose.
Okay. So we can use, so the options are we can use things like furosemide, okay, and we can repeat her kidney functions in 2 weeks' time, or she is on ramipril. How do you think about ramipril?
We can increase the dose of the ramipril.
Why? Her blood pressure is amazing. Any thoughts about ramipril and heart failure? Anybody knows?
It helps to get the fluids away. There are 4 of the medications we use for heart failure.
Right. Okay. Ramipril can be switched into indapamide.
Okay.
Why? Anybody knows why? Anybody knows why? What is indapamide? What is indapamide? Anybody knows? Indapamide.
Diuretics. Is it diuretics?
Yes, absolutely. And it is a blood pressure medication. So you see, ramipril can be switched into indapamide. Okay, so there are other options. So this is a point. I'm not saying that, so yes, absolutely, you did very well in management, but it's not as a point of a clear pass yet. You know what I mean? We need that. Think holistically. This is what we are teaching. Think holistically. Clear pass at some point, right? Perfect. Any questions so far? Any questions?
In terms of starting this bisoprolol, so what you would say, or should we call the patient and then see and discuss further if we are running out of time? So what you think about that?
No, I mean, Dr. Shishak actually has done it in a very good way. So bisoprolol is a very good medication that tends controlling your heartbeat. It's a very, very good one. And many people find it quite helpful, and actually they find that symptoms really settle down on it. However, sometimes people manage to report some cold hands or cold fingers, but most people really do well in it. At any point of time, if anything happens, please let us know, and then we can speak about an alternative. Now, following the patient up after bisoprolol should be done after what?
BNP?
Sorry? After what? What's the time frame for bisoprolol? 1 week. Bisoprolol needs to be followed up after 1 week. Why? Because if it's not controlling symptoms, we still need to tweak it up. Okay, so this is how we can follow the patient up when it comes to bisoprolol. But otherwise, it was fine. Safety netting follow-up, of course, will come if we have more time. We started our management at 5 minutes, but no, we're aiming for 6 minutes. Okay, if you have more time, you will manage your ability to get a clear pass is going to be higher and higher and higher. Okay, so why did that happen in the first place? It's because we didn't start with an open question, which slowed you down. And listen to that. Please, as much as you can, don't use too many questions all at one go. All right, perfect. So let's move to the following one. Dr. Ahmed, if you're ready.
Sorry, can I ask quickly a question, if that's all right, doctor?
Yes,
Just a quick one. In terms of, like, I know this patient is a heart failure. In terms of, like, why, because this is what we're doing. So in terms of the BNP, is it the worth to say that, okay, we do the BNP as well, just to make sure that how extent is that? And on the basis of if patient needs echo or anything like that, what are your thoughts on that?
Dr. Shehzad, this patient is already a heart failure patient. Okay, he's a known heart failure patient. All right, you don't have to worry about this now. This is mainly at the start of having heart failure. We do an echo, we do BNP, we do all of these things, but this patient is already a heart failure. He's known heart failure. He's just not taking his medication. He's not being treated